Welcome to the deep dive. Today we are wrestling with, well, a colossal challenge. How do you actually measure performance in the huge critical sector that is healthcare?
Yeah, it's massive.
We're talking about these vast organizations, hospitals, entire regional systems where performance measurement systems, PMS as they're called, aren't just, optional spreadsheets.
Not at all. They're really essential managerial tools. They allow managers to, the phrase used is pilot their institution.
Pilot their institution. I like that. It captures the scale.
And it's critical because, let's face it, the health system's been under the microscope for decades. Measurement is absolutely crucial for accountability, for quality improvement.
Right.
But what's fascinating and a bit worrying, perhaps, is that even though PMS have been essential for so long, recent research shows there's still no consensus regarding an effective approach.
Really? No consensus?
Not really, not on the specific metrics or even on the relevance of the different performance dimensions themselves.
Okay, so if there's no consensus, we definitely need a map. Our sources today, and this is quite a deep dive, based on a synthesis of 49 studies, 16 different frameworks, they help us see what is actually being measured.
And perhaps more importantly for you, the listener, where the critical blind spots are, what's being missed.
Exactly. So our mission today is to start by giving this some structure. We're going to unpack this classification of performance dimensions. They call them the stars, the runners-up, opportunists, and the forgotten ones.
That's quite a framework.
It is. And then we'll pivot. We'll look at what happens when these sort of careful academic measurements become concrete, sometimes really aggressive policy tools.
And for that, we're leaning heavily on the experience of the English health system, which has been, let's say, a real-world laboratory for this.
High stakes indeed.
Okay, so to understand what gets measured, you kind of have to start with the foundations. Thinkers like Donovan, his classic model structure, process outcomes.
Right, the SBO model.
Exactly, and frameworks like the Balanced Scorecard, the BSC, the recent literature we're drawing on organizes all this data into 4 categories, basically based on how often these dimensions pop up in the frameworks they studied.
So frequency is key here.
Frequency is the guide. Let's start with the ones that are always there, the stars.
The stars. Okay, the non-negotiables, what's first?
First up is access.
Access. Makes sense. This is about how easy it is to get care.
Precisely. It includes those classic measures everyone thinks of, like waiting times, ER waits, waiting for surgery, for diagnostic imaging.
The things that make headlines.
They do. But it also includes the slightly less tangible dimension of equity of access. Are services available to everyone who needs them, regardless of who they are or where they live?
That's a much harder thing to measure, I imagine.
It is, and access is a great starting point because just looking at that one dimension shows the complexity. We're not just counting minutes on a clock, we're trying to measure social availability, really. And it's also interesting that while affordability often comes up in discussions about access,
You'd think it would be central.
you would, but it's not systematically addressed with specific KPIs in most of these formal frameworks.
Okay, what's the second star?
The second star is effectiveness. This is all about the desired results, especially from the patient's perspective.
So outcomes.
Outcomes, yes.
Yeah.
Health status, quality of life, functional status after treatment, and of course, patient satisfaction.
And the KPIs here, are they standard?
Pretty standard industry stuff, yeah. Patient satisfaction rates, the number of complaints filed, patient mortality rates, and, crucially, readmission rates.
The bounce backs. Usually tracked within, 30 days?
Often within 72 hours or 30 days of discharge, yes.
Yeah.
It's a key indicator that something might not have gone right the first time. And sort of nested within effectiveness is patient-centeredness.
Okay, tell me more about that.
This is huge now for how care is perceived. It's about things like staff showing respect to patients, providing clear, accurate information in a timely way. It's where the hard clinical outcomes meet the actual human experience of care.
Right, the soft stuff that's actually really hard and important.
Absolutely. And the final star.
The final star is efficiency, but specifically viewed as productivity.
The resource side.
Exactly. This is all about getting the maximum output from the resources you have. I can run through some key metrics here.
Please do.
The main one is probably average length of stay, LOS, and the bed occupancy ratio.
Classic hospital metrics. Low bed occupancy means low efficiency, generally speaking.
Right. Managers also track things like throughput time, how quickly patients move through a process, and ratios comparing, say, real activity versus planned activity. Are we using our operating rooms or staff effectively?
Makes sense. So access, effectiveness, and efficiency as productivity. Those are the universal.
The stars. Okay.
So moving from the ones everyone measures, we get to the first runners up. These show up in most frameworks, but, not quite all of them.
Almost universal, but not quite. What's first here?
The first is the characteristics of staff, sometimes called staff orientation.
Focusing on the workforce. That seems absolutely critical.
It is. Employees are rightly seen as, well, the key mechanism driving performance. You can't deliver care without them.
So what are we measuring? Competencies. Satisfaction.
All of the above. Competencies, staff satisfaction, the staff mix. Do we have the right blend of skills? Key KPIs here include things like employee satisfaction scores, absenteeism rates, staff turnover.
High turnover is usually a bad sign.
A very bad sign. And also just basic counts like full-time equivalents. These metrics have a pretty direct established link to the quality and safety of care.
Yeah, you can see that connection clearly. What's the next runner-up?
Next is safety and quality. Now, this one is widely used, very well developed. Sometimes it's even grouped under effectiveness, but often it stands alone.
Safety indicators. Like preventing harm.
Exactly. Measuring harm from interventions, controlling infections. We're talking really critical metrics. Sentinel events. Those are the really serious, unexpected incidents.
Right.
Surgical site infections, medication errors, and tracking nasty resistant bacteria like MRSA and VRE rates.
The superbugs.
The superbugs. And quality assessment generally, driven by this huge push for evidence-based decision-making, is getting more and more emphasis.
Okay, that makes sense. Safety and quality are runners up. Now, the final runner-up, this is where I might push back a bit.
Go on.
It's efficiency again, but this time is economic financial. Cost containment, budgets, the money side.
Yes, that's right.
But why is the budget sheet, which feels like the absolute core for any public sector manager, only a runner-up? Shouldn't financial health be a universal star? I mean, for organizations always fighting budget constraints, surely that's the first thing they look at.
That's a really sharp observation, and you're right. It is a pillar of frameworks like the balanced scorecard, and it's absolutely essential for managers day to day.
So why not a star?
Well, when academics synthesize all those different frameworks from the literature, they often find that measures like, say, net profit margin, return on equity, or just controlling expenses within budget, they appear slightly less universally than things like patient mortality or basic access metrics, which pretty much every framework includes in some form.
Interesting. So it might highlight a slight difference between maybe the public reporting mission, what everyone has to report, and the internal managerial mission.
That could be part of it. It's a fascinating distinction, though, slight gap.
Understood. That split is really interesting.
Yeah.
Okay, so we've covered the stars and the almost stars, the runners up.
The core measurements.
Now let's dive into the shadows a bit. The performance maps darker corners, the forgotten ones, and the opportunists. These are the dimensions that the research shows are seriously underrepresented, sometimes outright neglected in these frameworks.
Yeah, and the forgotten ones largely map onto the structure part of Donabedian's model, structure KPIs.
Structure, like the foundations.
Exactly, and they're typically left out because, frankly, they are notoriously hard to link directly to processes and outcomes with solid statistical proof.
Wait a minute. If we know that the organizational foundation, how things are set up, is often the root cause when processes fail, how can the field justify ignoring things like organizational structure itself? Work design, the size of the place, how IT is used, or the contextual factors, the specific laws, the reimbursement model.
You're hitting the core tension right there.
It feels like completely ignoring the root cause.
The argument you see in the literature is often that these structure KPIs, and this also includes things like the characteristics of the population being served, their sociodemographics, they're seen as too far removed from the immediate patient outcome, too indirect for a manager needing a useful metric on a Monday morning.
So they're foundational, but maybe not seen as actionable levers for immediate management.
That's often the justification, yes. Management tools tend to prioritize direct, measurable impact on process and outcome.
That still feels like a massive blind spot, ignoring the context and the very foundation the system rests on. But okay, there are two other forgotten ones mentioned that seem particularly critical.
Yes.
Prevention. It's neglected in these PMS frameworks, apparently. Yet surely, preventing illness should be measured. Things like screening attempts, Use of preventative method.
Absolutely. If the goal is truly public health, not just treating sickness, then prevention ought to be front and center. But it often vanishes in hospital-centric performance metrics.
It disappears.
Okay.
And then there's this really odd one, attractiveness. You said it only appeared in one of the articles reviewed.
Just one, yes.
And it measures acquisition of new customers. Hold on. In healthcare. That sounds like it's straight out of a retail marketing pitch, not a clinical framework. Why on earth is that even considered a dimension?
Well, it might sound strange, but it's arguably becoming more important. As health systems, especially in places like Europe, increasingly move towards activity-based reimbursement.
Where money follows the patient.
Exactly. And funding gets tied to patient choice. Competition between providers increases. Even public hospitals find themselves needing to think about their attractiveness to patients who now have some choice about where they go for treatment.
Wow. That's a profound shift in mindset for public healthcare. Okay, so those are the forgotten ones. What about the opportunists? You said they were fluctuating dimensions.
Yeah, opportunists is the term used for dimensions that pop up inconsistently. Things like the research process or innovation within the hospital, appropriateness of care, making sure the right care is given for the condition, and continuity or coordination of care, especially across different providers.
And these only appear sometimes.
They often only seem to appear systematically when a specific comprehensive framework, like the balanced scorecard, is explicitly adopted to guide the whole PMS design. Otherwise, they can fall by the wayside.
Right, so unless you consciously choose a broad framework, you might miss them.
That seems to be the pattern. So if we try to synthesize all this, what the data really shows is that these KPIs are all interlinked. You can't just pull one lever.
It's a system.
It's a system. And focusing narrowly on, just say, effectiveness and immediate productivity while ignoring the others, especially those structural factors and prevention you simply won't give a complete approach of the drivers of performance.
So we're still missing a truly holistic picture.
There's definitely a persistent need, highlighted in the research, to define a more evidence-based structure of KPIs that properly links structure, process, and outcome measures together in a meaningful way.
But that perfect academic model, that holistic dream, it often seems to clash with the immediate pressures of politics and governance, doesn't it?
It absolutely does.
It feels like policymakers often don't have the patience for the perfect structure. They want action. They want results they can point to. So how do we get from these, elegant academic classifications to the messy reality of aggressive policy implementation using targets?
Targets. That leap is critical, and it's where the theory hits the road, often quite hard. Targets are incredibly powerful policy tools. They're designed specifically to achieve defined results within a fixed time frame.
Not just measure, but drive change.
Exactly. The concept isn't new. You can trace bits of it back to the WHO's 1981 Health for All strategy.
Yeah.
But the modern gold standard is that targets should be SMART.
Smart. Specific, measurable, achievable, realistic, and timed.
That's the one. That's the ideal, anyway.
And for a real-world case study in using targets aggressively, we look to England.
The English health system, the NHS, is arguably the ultimate case study. Back in 1998, they introduced these really ambitious public service agreement targets, PSAs. The explicit intention was to focus political and managerial attention laser-like on specific outcomes.
And the scope was huge, right?
Immense. Just look at the 2004 objectives to get a sense of scale. Objective I was all about population health. Really ambitious goals there. Increased life expectancy for men to 78.6 years by 2010. Slash mortality from heart disease, stroke, cancer by at least 40% in under 75s.
Huge societal goals.
Massive. And even tackling behaviors to reduce adult smoking rates to 21% or less. Halt the year-on-year rise in childhood obesity by 2010. These weren't tinkering around the edges.
And then there was the one that got all the headlines. Objective 3, access.
That's the one everyone remembers.
Yeah.
The public-facing goal that generated intense political pressure. It required ensuring that by 2008, absolutely no one waited more than 18 weeks from a GP referral to starting hospital treatment.
18 weeks max. That was incredibly ambitious given where they started.
Extremely ambitious. These were not modest improvement goals. They were demanding targets.
So the big question, did it work?
Well, here's the thing. In many ways, crucially, yes. The regime delivered. The PSA target system, which was backed up by performance ratings for individual NHS organizations, naming and shaming, essentially.
Right, the star ratings.
Exactly. It delivered major improvements in the areas that were specifically targeted. We saw a remarkably rapid elimination of those very long waits for non-urgent inpatient treatment that had plagued the system for years.
So the waiting list target, it actually drove down waits significantly.
Significantly and quickly. And comparative studies showed that targeted aspects of English care improved markedly compared to Wales and Scotland, which didn't adopt the same aggressive PSA target regime at that time.
So proof that targets can work to secure rapid change, at least in some areas.
They absolutely can force change and focus attention like almost nothing else.
Okay, but here's where, for me, it gets really interesting. We know the system can change quickly under pressure, but what happens when targets get too aggressive or maybe too narrow? Or when they ignore that holistic reality, that interconnectedness we discussed earlier? What are the perverse consequences?
The dark side of targets. The adverse side effects, the distorted behaviors, these are precisely what academics worry about. And interestingly, these kinds of behaviors were actually predicted decades ago in literature, looking at centrally planned economies, even Soviet examples.
Really, what's the core issue?
The issue boils down to this. If you measure and reward one single metric above all else, people inevitably start optimizing for the metric, not necessarily for the underlying goal the metric was supposed to represent. Goodhart's law, essentially.
Right. When a measure becomes a target, it ceases to be a good measure. Give us the classic healthcare example of gaming the system.
The most widely known one is probably the 4-hour target in A&E accident and emergency departments. The standard was a 4-hour maximum wait from arrival to admission, transfer, or discharge.
Sounds reasonable on the surface. Reduce waiting times in the ER.
It does, but it led directly to staff gaming the system. Anecdotes and studies showed staff might, for instance, refuse to formally admit a patient just before the 4-hour mark if they knew admission would breach the target. They'd hold them in corridors and waiting areas, so-called trolley waits, rather than acting purely in the patient's clinical best interest at that moment.
So the goal shifted from treat the patient efficiently and well to don't breach the 4-hour number.
In some cases, yes. The clock became the primary driver, not the patient's needs right then and there. It distorted clinical priorities.
Wow. Literally, managers watching the clock thinking, I need this to look good for the government report, even if it means delaying the next step in care. It sounds like something out of a bureaucratic satire, but it was real.
It was very real. And it wasn't just confined to emergency care.
No. Where else did it show up?
Well, remember that target guaranteeing access to a primary care professional within 24 hours?
Yes. Quicker GP access.
It led to some GP practices simply refusing to book appointments more than 24 hours in advance.
What? Why?
Because that way, they could always say they met the target. Anyone who got an appointment got it within 24 hours. But it completely subverted the real objective, which was supposed to be convenient access for patients, allowing them to plan their lives, book ahead if needed. Instead, patients had to phone frantically every morning.
That's perverse. Compliant with the letter of the target, but violating its spirit entirely.
Exactly. And there was another effect noted in the research.
Which was?
That local managers, quite rationally from their perspective, tended to concentrate their efforts on the targets that were easier to manage and measure, like those waiting times in Objective 3.
Because they could control the queue more easily.
Precisely. At the expense, potentially, of those less controllable, longer-term public health goals back in Objective at things like reducing mortality or tackling health inequalities. It's just much harder and slower to reduce smoking rates across a population than it is to manage a waiting list process.
So they triaged their efforts towards the politically hot, measurable targets.
It appears so. They focused on what was being intensely monitored and what they felt they could actually influence quickly. And the system also saw more overt problems emerge, too.
Like outright fraud.
Yes, unfortunately. There were documented cases of fraud and manipulation of waiting lists specifically to meet the targets. When the pressure is high enough, the temptation is always there.
So, given all these risks, the gaming, the goal displacement, the neglect of unmeasured areas, even fraud, how did the system try to counteract this dark side of the target culture? What were the mitigation strategies?
Well, it became clear that simply setting targets wasn't enough. Mitigation required building more institutional rigor and transparency around them.
How so?
The targets had to be augmented by things like strong national data audits and surveillance systems to check the figures were real. Professional inspection bodies played a role, and there was a push to ensure targets were truly smart, incorporating statistical robustness.
Getting statisticians involved.
Yes. For example, the Royal Statistical Society weighed in, stressing principles like ensuring targets were statistically sound, consistent over time, and didn't place an undue measurement burden on frontline clinicians, making the measurement itself more credible.
Okay, that makes sense. Audit, inspection, better design. What about those huge cross-departmental targets, like that joint obesity goal between health and education? Those seem really hard to manage.
They are notoriously difficult. And the key finding or recommendation there was about clear accountability.
Someone has to be in charge.
Precisely. It was strongly recommended that for any cross-departmental target, there must always be a designated lead ministry. One department takes ultimate responsibility for coordinating efforts and meeting the target.
Otherwise, everyone just points fingers.
Otherwise, accountability just diffuses into nothingness, and everyone blames the other department when the target inevitably gets missed. You need a single throat to choke, as they say in management circles.
Right. Clear accountability.
So if we try to pull all these threads together, synthesize what we've discussed, we keep coming back to this core tension
And tension between.
between the power of targets to secure political accountability and drive rapid success in specific, measurable areas like cutting those waiting times,
Which they clearly did.
and the ongoing need for a comprehensive, holistic view of performance measurement, the kind the academic literature calls for. The extensive research we reviewed consistently shows that really key dimensions, especially things like prevention and even that newer idea of attractiveness, are consistently neglected in operational frameworks.
They get crowded out by the focus on immediate efficiency and easily measured outcomes.
That seems to be the case. The urgent often drives out the important, especially if the important is harder to measure.
And it really leads us to a complex final thought, something for you, the listener, to perhaps mull over. The English experience powerfully shows that political accountability seems to demand simple, easily measurable targets, things the public and politicians can grasp quickly.
Yes, simplicity is key for political messaging.
But conversely, the academic research, the science of performance improvement, demands holistic, complex measurement systems, systems thoroughly linked from structure through process right to the final outcome.
The ideal versus the politically feasible.
Exactly. So the question for any large critical system like healthcare becomes, is it actually possible to design targets that are simultaneously stretching but attainable? The management ideal, maybe with, say, a 1 in 3 risk of failure to really push performance while also satisfying the government's inherent political need to minimize the appearance of public failure.
Can you have targets that are managerially effective and politically safe?
That's the dilemma. Can you reconcile those two demands? That fundamental trade-off seems to be right where the messy reality of performance measurement truly lives.